Welcome to This Week in Pediatrics. This week, we're covering 10 notable papers spanning newborn procedural safety and infection prevention, neurodisability and infection-triggered brain injury, and the wider world of nutrition marketing, allergy labels, and how we classify and protect vulnerable children. Let's dive in. We'll start in the neonatal intensive care unit, where two papers address very different threats to fragile infants. In pediatrics, Caxer and colleagues report a quality improvement initiative at a tertiary neonatal intensive care unit aimed at first attempt intubation success, which sat at a disappointing 45% at baseline. Root cause analysis pointed to two culprits: poor glottic visualization and patient instability during the attempt. The team phased in video laryngoscopy as the primary device and standardized apneic oxygenation with nasal high flow during laryngoscopy. Across 642 intubations, control chart analysis showed first attempt success rising to a sustained process mean of 61%, and critically, that gain held through a 10-month sustainability phase with video laryngoscopy used in 70 to 90% of attempts. The most striking signal was in infants under 1,000 grams, where first attempt success went from 38% to 62%, the group in whom repeated attempts do the most harm. Improvement was seen across all clinician types and all locations, which argues this was a system change rather than a few skilled operators. If your unit still treats video laryngoscopy as the rescue device rather than the default, this paper is a direct challenge to that habit. Staying with preterm infants, pediatric research published a multi-center Japanese cohort from Kamiya and colleagues linking breastfeeding status up to 6 months with viral infections in the first year of life among more than 3,000 preterm infants, followed through a national neonatal intensive care unit registry. Breastfeeding was associated with roughly a third lower risk of influenza infection, with a non-significant trend in the same direction for respiratory syncytial virus, rotavirus, and norovirus. Infection history came from parental questionnaires at 1 year, so recall and confounding by family circumstance are real caveats, but the direction is consistent with what we counsel already, and it gives you a concrete infection prevention argument to add to lactation support conversations with parents of preterm babies. Moving to neurodisability, developmental medicine and child neurology carries two papers on cerebral palsy that together say something about where the evidence is strong and where it simply isn't. Sogbasi and colleagues ran a randomized controlled trial in Benin of hand-arm bimanual intensive therapy, including lower extremities habitile, in 32 children aged 2 to 4 with bilateral cerebral palsy at gross motor function classification system levels 3 and 4. The comparator was usual physiotherapy, delivered at exactly the same dose, over a 2-week camp, which is the crucial design feature. This is a test of therapy content, not therapy hours. Gross motor function improved significantly more with habitile, and the gain was sustained at 2 months, while the usual physiotherapy group improved only slightly, and only at follow-up. Both groups improved on the Canadian Occupational Performance Measure, with a larger gain after habitile, and there was no change in bimanual hand function on the both hands assessment in either arm. This is a small trial, but it's a rare demonstration that an intensive, goal-directed protocol can be delivered in a low-resource West African setting and outperform equivalent dose conventional therapy. The contrast comes from Jeswal and colleagues, who systematically reviewed pharmacological and non-pharmacological treatments for sleep disorders in children with cerebral palsy, a problem almost every clinician in this space is asked about. 12 randomized trials, most of them tiny, covered melatonin, cannabis-based medicines, baclofen, neural stem cells, massage, cranial osteopathy, music therapy, acupuncture, and postural support. Only melatonin showed a modest benefit for sleep latency and duration versus placebo. Everything else was inconsistent or negligible. Adverse events were mild and tolerability acceptable, and there were no completed economic evaluations at all. The overall certainty of evidence was low. So when a family asks what will help their child sleep, the honest answer this week is melatonin, modestly. And beyond that, we are largely improvising. Also in the neurology space, the Journal of Pediatrics published a national Australian case series on infection-triggered encephalopathy syndromes from Chang and colleagues, drawn from the prospective Australian childhood encephalitis study over 11 years. Of 1160 children with suspected encephalitis, 220 met criteria for infection-triggered encephalopathy. A pathogen was identified in 83%, and influenza accounted for half of those, far ahead of enterovirus, SARS-CoV-2, and adenovirus. Median age was just over 4 years. Most children, about 3/5 of the cohort, did not fit a named subtype. Among those who did, acute necrotizing encephalopathy was the most frequent and also the rarest at a population level, at under 1 case per million. 60% of children recovered fully, but outcomes were clearly worse for acute necrotizing encephalopathy with biphasic seizures and late-reduced diffusion, and acute fulminant cerebral edema. The clinical message is a familiar one delivered with new national data. Influenza is not a benign pediatric illness. The febrile child with unexplained encephalopathy needs early imaging and pathogen testing, and this is one more argument for influenza vaccination in your clinic conversations. Turning to nutrition and the messages families receive, Pediatrics published a content analysis by Richter and colleagues of 389 toddler milk products from 14 countries across the Americas. Essentially every product, 99%, carried at least one front-of-package claim. Nutrition claims appeared on 97%, health claims on 56%, with brain and cognitive development the most common health theme, and about 1 in 10 packages carried an endorsement, such as being the #1 product recommended by pediatricians. Nutritionally, toddler milk averaged more total sugar than plain cow's milk, and less protein than both plain and chocolate cow's milk. In other words, a product marketed on cognitive benefit is nutritionally inferior to the milk it displaces. That is worth a sentence in the 2-year-old's well-child visit. Alongside that, Acta Pediatrica published a large Norwegian analysis from Odegaard and colleagues, using over 360,000 routine measurements from more than 124,000 children, tracking body mass index category transitions at ages 4, 6, and 8, and the probability of obesity at 13. Children with obesity at those earlier ages had a predicted probability of adolescent obesity between 38 and 51%. Children with overweight had a probability of only 8 to 10%, and, importantly, the pathway there barely mattered. Whether a child had recently crossed up from normal weight or had been in the overweight category for years, the risk was much the same. This argues for concentrating intensive early intervention on children who meet obesity criteria, rather than escalating alarm every time a child's body mass index drifts upward within the overweight range. Finally, 3 papers about labels and classification. In the European Journal of Pediatrics, Sadeghi and colleagues retrospectively reviewed 96 children aged 6 months to 15 years referred to 2 Northwestern Ontario hospitals with a reported amoxicillin allergy, who underwent direct oral amoxicillin challenge without prior skin testing. Almost 97% tolerated the challenge. Only 3 children reacted, all with mild delayed rashes, and all 3 had previously reported delayed reactions 5 to 10 days after their original exposure. So around 1 in 30 of these low-risk children was genuinely allergic, and direct oral challenge, skipping skin testing altogether, safely removed the label from everyone else. Also in the European Journal of Pediatrics, Hegge and Osfeld argue in a narrative review that sudden unexpected postnatal collapse, sudden unexpected infant death, and sudden unexpected death in childhood should be treated as 3 distinct entities rather than lumped together. Sudden unexpected postnatal collapse is rare and essentially confined to the first postnatal week during physiologic transition. Sudden unexpected infant death, at roughly 101 per 100,000 United States live births in 2022, peaks at 1 to 4 months, and is tied to modifiable sleep environment factors. Sudden unexpected death in childhood occurs mostly after age 1 and lacks consistent environmental risks, with signals pointing toward autonomic instability. Molecular autopsy has found variants in cardiac conduction, autonomic and neuronal excitability genes across groups, hinting at shared vulnerability in a subset, though the cohorts remain small. And in pediatrics, Gutierrez and colleagues set out an American Academy of Pediatrics policy statement on reception and assessment of immigrant children and families seeking humanitarian protection in the United States, grounded in the best interest of the child framework, and explicit that detention and family separation compound the health risks these children already carry. If you only have time for one paper this week, make it the Northwestern Ontario amoxicillin delabelling study in the European Journal of Pediatrics. Penicillin allergy labels follow children into adulthood and drive worse, costlier antibiotic choices, and this adds to the case that a general pediatric clinic can safely resolve most of them with a direct oral challenge. Here are the key takeaways from This Week in Pediatrics. First, video laryngoscopy as the default device plus standardized oxygenation during laryngoscopy produced a durable jump in neonatal first-attempt intubation success, with the largest gain in infants under a kilogram. Second, most children labeled amoxicillin allergic are not, and direct oral challenge without skin testing was safe in this low-risk cohort. Third, in cerebral palsy, an intensive bimanual protocol beat equal-dose conventional physiotherapy on gross motor function, even in a low-resource setting, while the evidence for treating sleep disorders remains weak beyond modest benefit from melatonin. Fourth, influenza was the leading trigger of infection-triggered encephalopathy in Australian children, and outcomes for the necrotizing subtype were poor, another reason to push vaccination. And fifth, watch the messaging families receive. Toddler milks carry near universal health claims, despite more sugar and less protein than plain cow's milk, and early childhood obesity, not overweight, is the signal that predicts adolescent obesity. That's your roundup for This Week in Pediatrics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty, to listen to in any podcast app, or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.